Bienvenidos a esta nueva edición del Webinario Internacional de Educación Continua en Vía Aérea, organizado por el Programa de Anestesiología y Reanimación de la Universidad Diego Portales. El programa de Anestesiología y Reanimación de la Universidad Diego Portales es dirigido por el doctor Ricardo Latrop Allende y tiene como objeto poder lograr formar un especialista capaz de ejercer la anestesiología en forma integral, entregando al paciente una atención acorde con la evolución de la especialidad, adaptándose a los cambios epidemiológicos y al desarrollo de la tecnología. Este programa de formación en especialidad médica está acreditado por la Oficina de Acreditación de Chile. Por lo tanto, ustedes pueden obtener información acerca del programa activando el código QR que ustedes tienen en su pantalla. Nuestras autoridades que respaldan esta actividad académica son el doctor Matías González, decano de la Facultad de Medicina de la Universidad Diego Portales, y la doctora Alejandra Quirós, directora de la Escuela de Posgrado también de la Facultad de Medicina de la Universidad Diego Portales. Contamos con el soporte académico también de la Sociedad Europea de Vía Aérea, la EAMS, y del grupo FIDIVA de España. Los invitamos cordialmente a hacerse miembros de la EAMS. Ustedes pueden ver en la pantalla algunos beneficios que tiene el ser miembros y también el costo de la membresía, que son 35 euros al año, que es un valor reducido para los países latinoamericanos y para residentes, estudiantes no académicos o no médicos que estén interesados en este tema. También pueden activar el código QR que tienen en la pantalla o ir directamente a la página web de eamshq.net. Contamos con el gran soporte de la empresa Traducciones Remotas que nos están ayudando a poder llevar esta actividad académica a todos los lugares de Latinoamérica y a España también, y Portugal, traduciendo las conferencias al portugués, al inglés y al español. Ustedes pueden activar las traducciones haciendo clic en un pequeño globo que tienen en la parte baja de su pantalla y activando el canal que corresponda al idioma que ustedes prefieran. Los invitamos a participar activamente en este webinario. Este es un webinario muy interactivo. Pueden hacerlo a través del chat, enviándonos sus saludos, sus comentarios. Nos encanta saber desde dónde nos están viendo y también, por supuesto, formulando preguntas para el conferencista. También pueden hacerlo levantando la mano, les vamos a ofrecer la palabra y pueden hacer de lo mismo sus comentarios y preguntas. Ustedes pueden ver acá la constelación de expertos que hemos tenido invitados durante este año, provenientes de diversas partes del mundo, desde Europa, Sudáfrica, también de Latinoamérica, de Estados Unidos, Irlanda también, han enriquecido esta actividad del programa de anestesiología. Aquí ustedes pueden ver el programa durante todo el año, partiendo desde enero hasta diciembre. Hoy nos corresponde el 30 de noviembre presentar a quienes les voy a describir a continuación. Aquí tienen una foto, es el Dr.George Kovacs. Nos conocimos el año 2016 en el Congreso de la SAM en Atlanta. A lo mejor, George, no te acuerdas de esta fotografía, pero yo sí la tengo guardada porque te considero un gran amigo y tengo una gran admiración por tu trabajo. Bueno, déjenme presentarles al Dr. George Kovacs. El Dr. Kovacs es un emergenciólogo canadiense que se desempeña como profesor de tiempo completo en medicina de emergencia con nombramientos cruzados simultáneos en los departamentos de anestesia, neurociencias médicas y desarrollo profesional continuo y educación médica de la Universidad de Dalhousie en Canadá. Trabaja clínicamente como médico de urgencias y es líder del equipo de traumatología en el Centro de Traumatología y Emergencias Charles Keating en Halifax, Nueva Escocia, Canadá también. Y es director médico del Life Flight, el programa provincial de transporte de cuidados críticos. El doctor Kovacs es director médico del programa clínico de donación de cadáveres de cuerpo humano de Dalhousie. Ha realizado importantes contribuciones como autor y editor de libros de texto y publicaciones revisadas por pares, incluidas directrices nacionales e internacionales multidisciplinarias relacionadas con su área de interés, el manejo de la vía aérea. Es un educador galardonado reconocido al recibir el premio del presidente de la Asociación Canadiense de Médicos de Emergencia, la CAEP, y recibió también la medalla del jubileo de platino de la reina por su trabajo durante la pandemia de COVID. El doctor Kovacs co-desarrolló el programa educativo sobre manejo de la vía aérea reconocido internacionalmente, el Airway Interventions and Management in Emergencies, el curso AIME, que ustedes pueden ver en su pantalla. Tiene 4 hijos y 2 nietos, y además de su pasión por la educación sobre el manejo de la vía aérea, le encanta estar en la cabaña que construyó en el río Medway y pasar tiempo con los 2 amores de su vida, su familia y su tractor Massey Ferguson. De esta manera, y en concordancia con su gran espíritu docente, el doctor Kovacs ha apartado generosamente parte de su tiempo para acompañarnos y compartir con nosotros su visión y experiencia en el manejo de la vía aérea de emergencia. Muchas gracias, doctor Kovacs.
Well, thank you for that introduction, Ricardo. And I remember that picture, and I remember where it was. We were at this Gulf area where it was a great gathering and allowed us to socialize. And that's probably the greatest benefit of these meetings is not only the content that you get to experience, but it's about the experiences that you share and meeting new friends that you've only met by distance. So thanks for that. Thanks for that introduction, and thank you for the honor of presenting here today. I'm excited, and I hope you'll more than enjoy this, but hopefully get something out of it and think about things perhaps in a different way tomorrow, or at least reflect on them. So again, thank you very much, and let's get started. So my name is George.
Perdona,
and,
George. Disculpa,
yeah.
George. ¿Crees que pongamos las primeras preguntas antes de que tú empieces?
Oh, yes.
Por favor.
Yeah. Let's start with that. So, you why don't you go ahead there? So, yeah, fire ahead, Ricardo.
Gracias. El doctor Kovacs nos ha enviado 3 preguntas y aquí yo quiero presentárselas para que ustedes nos emitan su opinión. Es un caso clínico de una mujer de 31 años, sana, madre de 4 hijos, que ingresó al servicio de urgencia con signos vitales normales, con disfagia desde las 5 de la mañana, y desde las 6 de la mañana se obstruyó su vía aérea debido a una epiglotitis por estreptococo grupo A invasivo, más una infección concomitante del espacio cervical profundo. Las preguntas del doctor Kovacs son: ¿creen que ustedes que esta es una vía aérea difícil? ¿Creen que es peligrosa? ¿Le produce temor a usted como médico a cargo? Entonces, por favor, respóndanos su opinión acerca de estas preguntas sobre este caso clínico, que se trata de una vía aérea difícil, que si es peligrosa y se le produce algún temor el manejo de esta situación. Ahí están votando. Parece que la gran mayoría está respondiendo que sí, que se consideran que es una vía aérea difícil, que es peligrosa y produce temor, produce una inquietud al menos. Finalizamos ya. Compartimos los resultados. George, ¿qué te parece? La gran mayoría sí considera que es una vía aérea difícil y que es peligrosa y les produce temor. Yo también.
Yeah, so I think we'll circle back to this, and you know, this is not somebody that you're going to have to do
Sí,
a formal airway assessment, right? This is somebody that's from the foot of the bed is frightening,
muy bien.
and there are 7% of people who said that they're not afraid of this airway, and I'd love to meet them and help them hold my hand in this situation, because I've been doing this for 35 years, and this does cause my heart rate to go up, and we'll talk about how that affects performance. So I'll leave it there, and we'll circle
Claro que
back to
sí.
this later.
Vamos a la segunda pregunta. También es un caso clínico, se trata de un paciente de 59 años, obeso mórbido, con síndrome de apnea obstructiva del sueño, con barba, dolor dental, secreción purulenta sublingual, macroglosia, de la lengua grande, falla respiratoria hipercápnica, retenedor de CO2, y tiene los siguientes signos vitales: presión arterial 90-60, frecuencia cardíaca 110 por minuto, frecuencia respiratoria 28 por minuto, saturación periférica de oxígeno 76% con oxígeno ambiental. Y la pregunta del doctor Kovacs se asume, ¿y por qué creen ustedes que esta es una vía aérea difícil? Porque hay una dificultad anatómica, porque hay una dificultad fisiológica, otros factores o todas las anteriores. Da la impresión de que efectivamente es una vía aérea difícil, pero es importante determinar si es por alguna de estas razones o todas.
100% perfect. And
Sí,
again, you know, when you look at this, again, we don't have to use a mnemonic to sort of identify whether this is difficult anatomically, difficult physiologically. These are cases all that I've had, and this is actually somebody I did an awake intubation on. But yes, so, and again, the anatomy and physiology we'll be able to identify. We're going to be talking about the other factors here, but the more issues there are, the more other factors that influence outcome.
perfecto. Vamos a la tercera. Ah, la apagué. Ponla de nuevo, por favor. Accidentalmente
Yes,
la apagué. No la veo.
that
Ahí
was it.
está. La tercera pregunta es también un caso clínico de un paciente de 35 años que presenta una sobredosis por polisustancia y que aspiró. Tuvo una aspiración bronquial. Trata de sacarse la mascarilla facial, está agitado y sus signos vitales son frecuencia cardíaca 125 por minuto, presión arterial sistólica de 90 milímetros de mercurio, una saturación periférica de oxígeno de 81%, frecuencia respiratoria 36 por minuto con máscara de no recirculación. ¿Cuál desafío cree usted que le preocupa más a usted? Primero, la intolerancia a la apnea, la intolerancia a la inducción, la transición a la ventilación a presión positiva o su capacidad de desempeñarse en una situación estresante. Es decir, al manejar a este paciente, ustedes lo van a intubar, ¿cuál es el desafío que más le preocupa? La intolerancia a la apnea, es decir, que desature rápido, la intolerancia a la inducción, es decir, que haya un colapso por la inducción con drogas, o la transición a la ventilación a presión positiva, es decir, que se pasa de ventilación espontánea a ventilación asistida por presión positiva, se puede producir un problema también. O la capacidad suya de desempeñarse en una situación que realmente es estresante. Bueno, ahí están votando. Hay, hay tres preferencias mayoritarias.
And the key thing here is what's most,
Ya,
recognizing that they are all, but for you, which one worries you the most?
más. Es la que más les preocupa. Aquí están listos los resultados. Parece que a nadie le preocupa el estrés, George.
Well, 18% of them are, right? Yeah, and there's no right answer here, right? Because they're all right. This is not a right or wrong. These are the things that you need to think about.
Exacto.
And if you don't think about them, then it will become an issue. And then as you're performing this, bad things are going to happen, and your stress response will get worse. And what we know about this is that your ability to perform as saturations are falling in the background, and there's a nurse in the background who's deliberately calling out the saturations as they fall. This affects our performance. And we're going to circle back in the end, and I'll tell you some of the results of what happened to these patients, and that'll be a lead into some further discussion.
Muy bien.
Are we good? Okay. All right. So thanks for that, and thanks for taking the time, and thank you. You all got A plus from a grade, and let's start the conversation here. So again, my name's George. I am a Canadian. Ooh, and there we go. This is one of my grandkids. This is a time of year in Nova Scotia when leaves are falling, and there's lots of maple leaves on the ground. This is my older of my two grandchildren, Graham. I'm not on any form of social media. I actively or intentionally left all forms, Twitter, what it's called, X, Facebook, Instagram. You won't find me anywhere. And that was just sort of a personal decision, and I'm not going back. If I got something to say, I will put it up on we're transitioning our website, and aimairway.ca. And we have a YouTube channel, and so talks that I've given are available there at AIM Airway. So that's where you'll see me, but not on social media. This is where I live in the east coast of Canada, in the province of Nova Scotia, and the city of Halifax. I work in a large volume emergency department and trauma center. And as stated, I'm the medical director for Life Flight Critical Care, which provides critical care transport to the sickest of the sick for not only our province, but neighboring provinces in the maritime area. But many of you have seen me speak. I will refer to certain things, and this is my place of refuge, which I'm going to go to after I finish giving this talk. Is a place I built in the woods 43 years ago with a chainsaw and a handsaw on a river, and it's a place of refuge for mind, body, and soul. And play takes on a different meaning. I now have a mill area and manage the forest and what trees I take down. I think about everyone, but these are my new toys that I use in the woods, and I get to spend time with a growing family of not only kids and grandkids, but dogs. We have 5 dogs in our family that trape around and jump in and out of our river. And then this is my most responsible thing. I was given these socks. This is a cool ass grandpa. And that's a major responsibility for me. I do need to acknowledge that this is what I'm giving this talk from my office, and I do receive protected time support from Dalhousie University Department of Emergency Medicine. And as I said, I'm cross-appointed with the Department of Anesthesia here. We've been providing AIM, Airway Interventions and Management in Emergencies, an airway program that is both goes on the road out to locations around the country, and then we also have cadaveric-based courses that are offered here, and we're associated with the Canadian Association of Emergency Physicians. I need to acknowledge all of these for supporting me in what I do. And I do receive no support from any brisket making company, but I will tie in the title as to why this it is entitled what it is, and lessons from cooking brisket. probably the most important acknowledgement that I now do at the beginning of every talk is acknowledging my greatest teachers. And my greatest teachers are those people who have donated to our very robust human body donation program. And about 15 years ago, after visiting Baltimore and spending time with my brother from another mother, Rich Levitan, we ended up bringing back what he'd been doing and establishing a clinical cadaver program and changing the way that these are prepared. I speak every year at the internment or funeral closure for those people who've donated their bodies, and they have collectively saved more lives than anybody who's on this webinar have, or all of us collectively. This is Rob Sandusky, who manages the program, who's a close friend, and really its success is related to him and his team really wanted to make this happen. So thanks very much. I had seeing this translated and seeing translated here in this poster, and with in particularly referring to brisket was a very important thing. What's in the background is I do a reasonable amount of speaking, and it's about knowing your audience. And over time, I've had the privilege to speak to different groups. And what I'm going to do is, even though I'm talking about cooking brisket, one of the themes here is going to be about playing with fire and our approach with fire, and turning playing to fire into owning the fire, and sharing that fire. And it comes down to this. It was interesting. There's a friend of mine who teaches the French version of AIM in Montreal, and he has no cell phone, believe it or not. He works in downtown Montreal in a hospital, and he has a place in the woods, and he's very passionate about cooking with fire. And he sent me this about a week and a half ago, and so Francis Mailman, who and Aaron Franklin are two of my mentors with fire. And Francis Mailman is from Argentina, and you see that little heart area not far from where the crow flies from Santiago, just a few mountains in between them. He is a place very remotely on an island, and he's offering this course in February. And I said, well, maybe I'll go and I'll be able to come down and visit you and all of this. But I looked up the cost of doing this. So the cost of going this and taking this 5-day course taught by both of them would be 35,000 American dollars. That translates into 50,000 Canadian dollars, and that's before you fly down. And then it's a 7-hour drive from Buenos Aires, and then a 2-hour boat ride to get to his island. So I'll have to think of another reason that I can afford to get down there. Sharing the fire, and the metaphor here is about, that's what, when we're looking after sick people that need airway management, we're dealing with fire, and what we need to do is turn it into something constructive instead of something that is destructive. And hopefully this is going to play here, but this is Francis Mailman. Ah, you don't. No voice? Sorry, folks, were you able to hear anything?
We
Oh,
are
that's
hearing,
unfortunate.
we are hearing you, George.
Just me. Okay, that's unfortunate. But can we try this one? Is that doing anything now? Can you hear no? Okay. Okay. All right. So you can't hear anything? Is that correct, Ricardo? Okay. All right. Okay. Yeah. Okay. Let me just, yeah. So I have to stop share then, in order to do that. Right. So share screen, more, hide audio, optimize. Optimize for video sharing and share computer sound. Okay, that's what we have to do. Yeah, yeah. Okay, there we go. Give me 1 second, folks. Apologize for this. All right. Issue with flow. We'll just try this one more time. It's not a biggie if this doesn't happen. How about now?
I always think of having a big fire and putting around the fire people from all around the world, young, old, students, scientists, writers, artists. The first thing that happens, there's this very long silence. Fire is innate to us. It's been with us for thousands of years. It has been our protection, our food. The moment you see fire, you recognize something that is inside of you long before you were born.
Really started happening about in the 60s is when brisket started becoming a barbecue cut. It's a pretty lowly piece of meat on the animal, really. It's not a tenderloin, it's not a ribeye, it's not a strip, it's not a T-bone. It's just a tough, big, weird piece of meat with a lot of fat. It's lean on one end and really thin. It's fatty on the other end and it's really thick. So it's kind of perfect for slow cooking over fire. That's kind of how we got here in Central Texas. And that's kind of how brisket ended up being like the Texas cut of meat. And then you
So I'm going to cut that short in the interest of time, but these are two of my mentors that cook with fire. Francis Mailman is more elaborate and is a Michelin star chef, and Aaron Franklin cooks brisket out of Texas and has become an international phenomena. And it's been a motivating person for me over the years. And this is a picture of me sort of bringing brisket to the resuscitation room, understanding the metaphor of taking this tough piece of meat that nobody really wants and turning it into something that's successful, something that you can share with the people around you. So human factors, psychologically difficult and dangerous airways, lessons from cooking brisket. I'm not going to be getting into great detail about some excellent literature that's out there that I'm sure either you know of and you've read similar material. these are perspectives from, as I said, perspectives from life, and afterlife, and as well as cooking from brisket. And I'm going to take you back a little bit because it's important to understand how I got here. I finished back in 1990 my internship, and then that next day I was working at a small community hospital where it was me and a nurse, and I was, cocky. I thought I knew everything. And a train hit a vehicle, and at that time the system, the pre-hospital system, was run by taxi drivers who would get out of their taxi, drive to the funeral home, and pick up the ambulance, and then go and respond, single response to a place. And they were bringing in a patient from a car versus or train versus car. And I remember just, opening up the door, nervous, thinking about this patient arriving, and the driver opens up the back of the ambulance and pulls this person out by his feet, throws him over his shoulder, and takes them in and plops them down in a resuscitation area. And my heart rate went down because there was nothing I could do because this person was dead. And then he said, "Let's go get the other one." And there was another one in there that we both carried in. And I remember doing that resuscitation, and this person survived, and it has nothing really probably to do with my care, but more the fact that the human body is resilient. And I remember driving back and said, I didn't want to feel this way anymore. So it was fear that drove me here this way. And ultimately, it drove me back to do a residency in emergency medicine. And I came back to Halifax, where there were clinicians that were dual trained in anesthesia and emergency medicine. And that's really the path that it brought me. And it turned this fear really into opportunity. And you'll recognize various people on this screen that I've had the great fortune of working with. And I have to tell you, I feel in some ways and many times an imposter as an emergency physician. I've gotten over that because I do what I talk about. I'm not somebody who's going to talk about stuff that they don't do themselves. And it's created great opportunities over time. And we've been able to sort of spread this opportunity beyond. This is Jules Santos to the left, who's in Brazil and is taking a leadership role in teaching airway management to her court. And she just sent me this about 5 days ago, and using clinical cadavers. And then you'll see on the right, there's a person that many of us know is Carmine Della Vella, who again was a paramedic by trade, and then has gone back and done medicine, and has become a leader as an educator, spreading the word and teaching passionately airway management around the world. Now, I said it was fear that guided me, but it was also some stupidity. As an airway educator, I probably have the most instrumented glottis in the world. And then you guys know this person who's spoken here. This is Ross. This is Ross and I when we were at the World Congress meeting in Singapore not long ago. So I still think I've got it up on him. It's the reason why I have this radio voice, is because I probably banged around my larynx so much over time. So lessons from life. And life is, life is good. Life can be tough, and it doesn't always go as intended. This is my tractor, and it's not meant to be on its side off the road that I have to pull out with my truck. And we have to, look at things in creative ways, right? There's some bougie artwork that's in my office, and we understand that while you might look at somebody and they look okay, this is somebody with a clearly scary airway on the left, and this is me 2 weeks ago managing a 24-foot piece of lumber on a road that makes it a challenge to get through. And lessons from cooking brisket. And brisket's about, the right occasion, the right procedure, right material, right gear, the right preparation, the right execution. And that's the same thing from airway management. If you take a piece of this tough piece of meat and throw it on a barbecue and just expect to sort of cook it in an hour, people are going to leave your home in disgust, saying, why would you serve that? Right? You need to have and people cook brisket for, they'll only do it for special occasions, right? So they'll do it for, a wedding. And isn't she beautiful in the background? Yeah, I know. That's a 1957 Massey Ferguson. Right. That's and my daughter there, and then two of my grandkids. But if you cook brisket on just special occasions, If you just expect, these special occasions, these rare events to teach you how to do something, then bad things are gonna happen. You need to be able to cook brisket on a Tuesday, because patients don't show up, when you're ready and had just finished training. They're going to show up on a Tuesday, they're going to show up on a Thursday, or whatever it is. So it's not about just doing on the right occasion. You need to be prepared to do it all the time. This is my smoker in my backyard that a friend of mine custom made, and I need to be able to do it when it's -20, or it's a summer day. This was when my first grandson was born. We had brisket for that occasion, and the brisket weighed much more than he did. So playing with and sharing fire, the successful airway. This is a case that happened 5 days ago. And so I was working in the department, and a patient, a 68-year-old, walked into our department with dyspnea, with shortness of breath. And they were supposed to have some sort of ENT surgery in a few weeks. Their saturations are normal on room air, but they have normal noisy breathing, and was diagnosed by our triage team as audible wheezing. And we have no space, we have no monitor bed, and they're in a wheelchair going to a non-monitor room, and we're wheeling by a colleague of mine on her way to her lunchroom, and she stopped because she could hear a sound that wasn't wheezing. And what do you think that sound was? You don't know. They're going to see ENT. That sound was Strider. And Strider, a good friend of mine said this, and mentor Mike Murphy says, acute Strider is just the sound that people make before they die, right? So it's something that we need to respect. And this is very important, is to understand context, our department on that day, and hopefully you're going to be able to see this. This is walking out into our resuscitation bay. Let's see if that's going to play. Is that playing? I'm going to skip down here, but I'll go by. There are 17 ambulances. 17 ambulances in our department. There are actually no ambulances in the city because they were all trying to offload patients. At the same time, a chopper is landing, right? So we have no place to sort of see these. Now, when I hear about this case, my first thing was, somebody go and look, what procedure they're doing. And without getting into the detail here, I'm not sure if you can see my pointer, but this was 3 weeks prior. This person was booked for a laryngectomy, and clearly they had a distorted airway then, right? So this is playing with fire. And this case was all about doing nothing. You're not touching this person, right? Keeping them sitting up. And I'm not going to get into detail with this, but this is about calling my colleagues. This is about calling Ricardo and say, Ricardo, we've got somebody with an upper airway obstruction, and they need an awake trach, right? And because I tried to actually put an ultrasound probe on their neck, and because they actually had a C3, C6 fusion that they couldn't extend their neck, I couldn't even put the ultrasound probe on. And so ultimately that's what they had. And this was the scope that we just did, nasal scope that we did in the ED. They have a 4-millimeter airway, right? So this is understanding, playing with fire, and knowing when to not touch fire here, because you would have killed that patient. So success in terms of airway management, we all understand this. It's about anatomy and pathology and physiology, and context affects our decisions, right? Whether we're going to do an RSI or whether we're going to do this person awake. And we all know this. We train. This is common stuff. But what we need to optimize is the other parts, right? Is the provider optimized? What equipment do you have access to, and what support do you have? And I build this around the 4 C's. And many of you might have seen talks that I've given in the past. And I build things around the 4 C's, but for every talk I do, it's different. So there's some common points here, but there's some different ones here that relate to playing with fire. And the four main C's are competence, context, confidence, and conscientious. And when I spoke in Atlanta, this is the first time when I introduced this was the psychologically difficult airway at that time, those years, many years ago. Halifax is a great area for cold water surfing. I've taken my son, when he was young, walking through knee-deep snow for him to go in and hit waves like this. But, things don't always, you don't put on a surfboard and you don't just sort of expect to get up in this. It's dangerous. It's dangerous for all kinds of reasons, not only from those big waves, but from the temperature and these other factors. So success, in order for you to have success, you need to appreciate these four components. And we're going to begin with competence as it relates to managing fire and working with this, turning fire into something that's productive. We never, at our cottage, at our place, our cabin, we never cook over with a barbecue. We always cook over fire. And that we've been doing that for 35 years. So patient outcomes, we have to optimize their scenario and our scenario to have decent outcomes. So let's begin with competence. And this is a classic pyramid, George Miller's pyramid. It begins with those who know how, those who show how, and those who do. And really what we care about is what they do. Now, show how is about, how many and how long. That's what competence is. Competence is an educational outcome, right? It's something that we measure. It's in the context of as residents and medical students. And that's something different. So we look at what's the number needed to be competent in certain things. Is it a number for airway management, 10, 50, 100, 150? Or is it how long you spent in various rotations that you spent 6 months, 12 months, 18 months, 2 years, 5 years? And that's the way we do it. Now, at the end of it, we measure that, but it's based on these surrogate markers. How much practice is a person by the name of Malcolm Gladwell, and he's written many books. And interestingly, he's recapping these books and reassessing what he spoke about and wrote about a number of years ago. And he's got this book called Outliers. So how much practice? And in that, there's a chapter called 10,000 hours, and about 10,000 hours, which is about 10 years, is sort of that what's required to become a master or expert. And people argue about that. And my kids remind me that this rap artist by the name of Macklemore also has a song called 10,000 Hours. And he articulated it this way: the greats weren't great because at birth they could paint. The greats were great because they painted a lot. Now, Anders Ericsson took it differently, and he said it's not about how much, it's about what type of practice and deliberate practice. And what is deliberate practice? Break it down to something very simple. And what it really gets down to is timely feedback. Is that you're not just doing it and doing trial and error. You're doing it and somebody's able to see, no, you're lifting too hard, or you're lifting too proximal, or need to go down a little bit further, no, your bougie needs to be, etc. So that's that timely feedback. And those are deliberate practice events that can shorten the time it takes to become skilled in what you do, as opposed to just doing numbers. And that's the difference between that. So competence is about how many and how long. We care about performance, and performance is what you do in the real world. So we're trying to predict based on competence that when you get out there, you're going to perform well. So we care about and look at markers such as outcomes, morbidity and mortality, first pass success, which I'm not a fan of, first pass success without adverse events. So let's get back to a case to get us more balanced. This is that one that we talked about, a 35-year-old polysubstance overdose aspiration. They're tachycardic, the blood pressure is low, their saturations are 81%, they're tachypnic, and they're on a non-rebreather. They're not getting an FiO2 of 100 because their respiratory rate's 36, but we say put them on 100%, which is a non-rebreather, and they're going to be in training, but we're doing the best we can and they're pulling off their mask and they are agitated. If we were to sort of say, well, they're agitated, we just have to put them off to sleep and get the damn tube in, then you are playing with fire, right? These are people that die. right? They die post arrest because we haven't really optimized that scenario. So first pass success. I got to stop saying this, but I'm halfway through an editorial saying about first pass success, and excuse my language, but who gives a shit, right? Or who cares, right? So first pass success doesn't necessarily mean that it's successful. You need to resuscitate your patients before you intubate these patients, right? And if you were to push drugs in that patient, then this would be a nail in the coffin. And a preventable nail in the coffin, because the goal of airway management is to oxygenate, ventilate, maintain physiologic homeostasis. And as Rich Levitan has said, is patients don't die from acute plastic deficiency syndrome. They don't die because you didn't put a tube in. They die because you didn't pay attention to this kind of detail. And rather, RSI should be switched to resuscitation sequence intubation, another term that was coined by him, which is, slow down, fix your stuff before you go in, and then go in. And that could be 5 minutes, 10 minutes, 15 minutes, 20 minutes. I can't remember the last time I've had to jump in and do an emergency airway. I need to do it right now. If I do, it's because they've lost their airway and have to do a jaw thrust and open their airway. But putting a tube in, almost everybody, you've got time to do this. So let's say that we've got this patient, we put them on oxygen, their sats are 86% now, right? So their heart rate's down, their blood pressure is systolic blood pressure, they're still markedly tachypnic. And you want to put them on non-invasive ventilation because you read that recent pre-oxy trial and want to do it, but there's nothing available. It's being used or you don't have it. So what we're doing is, you might say, well, geez, this is the best I can. There's nothing available. I've been doing this. I've been mass ventilating, assisting them. Their sats are 86%. Well, again, if you were to push these drugs, it's going to take 3 seconds before this person is critically desatting. So you again need to have different monitors that give you the feedback. I would not push the drugs in this scenario. I'm going to use my device, and my device we call the Super BVM. And what Super BVM is having this setup. We've got a pressure manometer, we've got PEEP valve, and got waveform capnography attached to our viral filter. And we're using this preemptively to say, okay, our sats are 86%. Why isn't it getting better? Well, if we had waveform on and we see a terrible waveform, it tells us, our seal's bad. So all we have to do now is make some adjustments, sit them up, adjust the seal, and then all of a sudden things have improved. So we're using waveform not as an end post-intubation, but we're using it as part of our resuscitation to guide our oxygenation, guide our seal beforehand. So lo and behold, you do that and the saturations improve. So we use 2 monitors for oxygenation, right? We use our sat monitor, which is our pulse ox map, but the only thing that gives you breath-to-breath feedback, the equivalent of having an open lung window, is waveform capnography. So using that beforehand to adjust your seal is very helpful. And then again, you're using your devices here, a pressure manometer, to make sure we're not overventilating our patients in terms of pressure. And we're not driving down the CO2, because what do we do when the saturations are low? We do this. We start squeezing the back. Right. And what I'll show you in a second is with this, and this is with PEEP on, with one of our cadavers here. This is, PEEP, respirator. You put on a PEEP valve. This is 10 a PEEP. And within 3 or 4 breaths, you've fully recruited alveoli here. After 5 or 6 breaths in this scenario, all you're doing is you're not affecting oxygenation anymore. You're just dropping their CO2. Now, I'm not saying to do that at 6 breaths a minute. You're going to match what they have from a minute ventilation beforehand and do that throughout. But you don't have to overventilate that patient. Don't go above what their baseline ventilation is to reoxygenate your patient. Just use the right device in that scenario. Competence and performance is also about knowing how to go in. I was taught Rich Levitan. I get these cold calls from him, and sure enough, he called me about eating a sandwich last night. He's over at Das in London, this salt beef sandwich, and we talked for too long. on this, but how do we go in? And this is just our approach in terms of adult rapid sequence emergency medicine and emergency medicine. You're doing your PPE checks, your team brief, your checklist, etc. And then what we recommend as your primary approach is optimized video laryngoscopy, and that can be with whatever. And again, I recognize that many parts of the world don't have access to video laryngoscopy, and I acknowledge that. And I'm still a big believer that good skills with direct laryngoscopy and a bougie are very helpful. I'm not naive that everybody can afford and have access to it. But in places that you do have access to it, video laryngoscopy definitely adds value for sure. And that can be with a Mac device or with a hyperangulated device. But what we need to understand is we need to also change our language, because it's not about using a video laryngoscope. It's all about the blade, right? So understanding what blade, and really there are two types of blades. There are Macintosh type blades. Now the GlideScope came out with a hyperangulated blade, right? And the CMAC, well, what did it come out with? With a Macintosh blade. But all of these, and below is the McGrath Mac, all of these devices have both Macintosh standard geometry blades and have hyperangulated blades. So when you refer to it and your team is working with you with this, you need to refer to the blade type. I'm going to use a Macintosh style blade for this patient, or I'm going to use a hyperangulated blade. And Adam and I wrote an editorial about this, about video laryngoscopy 2.0 and changing the language here. And then it's about what's your approach. And we coined the phrase EVLI. And again, Rich talks about epiglottoscopy. You know, fortunately, these videos seem to be stuttering a little bit. But epiglottoscopy is about going in and looking for your friend. Your friend is the epiglottis, because when I can see the epiglottis, I know where the glottic inlet is. And so you're going and look, because what do we do when we're excited? We dive deep, we lift hard, and we pray, right? And what you need to do is deliberately do gentiloscopy, right? Which is finding that special place, and that special place is the vallecula, and we refer to this as valleculoscopy. And what valleculoscopy is that if you can see the median glossoepiglottic fold, then you're too proximal. And you can lift that with any amount of force you want, and you will not get a better view. As opposed to if you move down 3 millimeters in the same patient with a 2-finger lift, you're going to get a great view. This requires fine motor movement. And this is the difference between an inexperienced person going in and having a terrible view, and an experienced person getting a really good view. And you need that fine motor control. You need to understand this anatomy and where your blade tip is. And that's what we refer to as valleculoscopy. And then it's laryngoscopy. And we all know that with Macintosh, the more you see, the better it is. It's bad when you see just epiglottis, in particular, a 3B view when it's deflected posteriorly, which I will say is almost always iatrogenic. In other words, we're going in too far when deflecting the epiglottis posteriorly. And a grade 4 view, I've seen 1 in my career. Adam has seen 3 in his career. I judge a study by how many grade 4s that they've seen. If they've done 1 or 2%, they've either got weird anatomy, or what I contest, they're actually in the esophagus. That's what they're doing, because a true grade 4 really should be quite a rare event. And with Macintosh laryngoscopy, despite original positioning, this is a view that got a lot of views when I was on social media, is that beyond being in the sniffing position, you move your hand to the occiput and you do an additional head lift and then put towels in. That's the most powerful move to improve your view, the EVL portion, the laryngoscopy portion of that view. And if it doesn't work, then you reach around with your right hand and you do ELM. You're just pushing the larynx towards you to try to get that better view. So it's bimanual laryngoscopy. And then it's intubation. And just I play hockey twice a week with a group of people that are in their 60s. I've taken 2 of my colleagues there. One was a dislocated shoulder that we played with. And then last week, one of my defensemen got hit in the larynx with a puck. And so I escorted him to the ED. and he scoped and had laryngeal edema, but he was back playing with us this week. In terms of shaping your tube, really for a Macintosh blade, it should be straight to cuff and then a 30-40 bend. People refer to that 90-degree bend as a hockey stick. That's a field hockey stick. That's not really what a hockey stick is, and you should shape appropriately for Macintosh blades. Now, if you're using a hyperangulated blade, from a laryngoscopy perspective, the view on the right is counterintuitively, oh, that should be easy. The issue is that you are looking up to the anterior wall, and you're seeing that anterior wall, and that little bump in the white here is the cricoid cartilage. And that is a challenging view to get to. And really what you want is this deliberately restricted view where you're looking down the long axis here. I'm not going to get into shaping. There's a lot of people who are very passionate about how to shape the tube. Feeling is that it should be a 60 to 70 degree bend. And the way I do that is I go to 90 and then I back off a little bit to get to 60 to 70 degrees. From an intubation perspective, this is the issue. What happens if you have that view that's too good is that you will come up to, and you actually get it caught on the cricothyroid membrane, hung up on that cricoid cartilage. As opposed to if you have this deliberately restricted view, then you're able to sink the tube more easily. The other little pearls that are there is, again, rotating the tube down to the right, because then it puts the distal portion of the tube in the same trajectory as the trachea, and you can pull it back. I'm going to move through these fairly quickly. The other thing that's really important is once you get the tube in, just don't come out and say, yeah, we got the tube in. Spend 4 or 5 seconds to confirm that you see something posterior and something anterior that you recognize. I'm going to move through this in the interest of time from a bougie point of view. Recognizing that a bougie, as we're all familiar with using, it just has a coude tip, it's straight. They all should have some degree of memory. In other words, you bend them and then they will retract in a certain amount of time. And when to use a bougie, you should, whether you're a believer in using it all the time, and we are believers of using it all the time, but you're not going to use it when you have an epiglottis only view and it's tilted backwards, or obviously when you have a grade 4 view. So there's out of the package, this we refer to as a pillow bend. This is what we call deliberate bend that we'll use with a hyperangulated blade, and there are steerable tipped ones that are out there. We recommend doing a pillow bend all the time. And I'll tell you why, is because there are some differences in Macintosh video laryngoscopes where they actually are taking around the corner a little bit. So sometimes you'll end up posterior with your bougie. So if you do just a slight pillow bend, not a big bend, then that will compensate for any differences between Macintosh type blades. Right, it's something, again, that we do routinely. It's not putting a big bend, but allow you to compensate. And the other thing I'm going to say, we all understand, is that your tube will sometimes get caught on right-sided structures, and you can remember to rotate it to the left, but do different all the time. So what we teach is about doing a preemptive term. Every time I put a tube over a bougie, I'm rotating it off right-sided structures as opposed to reacting to difficulty. A lot of people question this, the 98% first pass success, and that hasn't been reproduced in studies that we're all aware of. But to me, this wasn't about the bougie. This was about an airway bundle and about an institution that puts a big package together. And it wasn't about the bougie being a heat-seeking missile. This was about, yes, the bougie being used successfully because they practice a lot. That was a lot on competence. What about context? Well, context is this, is that if I put the tube in the right place, that's fine. But if I do it and they've got a blood pressure of 60 or they're in cardiac arrest, the context is about what's important. What defines success and failure? Is this a successful airway? You're going to see this go in and boom, you're going to say, the tube's in. And I would put this up as a question, is this a successful airway? And the answer to this is, I don't know. I have no idea. It looks like it went in the right place. This is a study from Davis when they were back in the early 2000, mid 2000. They were looking at doing rapid sequence intubation on head injured patients in pre-hospital setting. And this is a case in which the patient started with SATs of 100%, but during intubation, their SATs dropped to under 80. And then their CO2 dropped to under 20. And that wasn't therapeutic hyperventilation. That was essentially adrenaline-induced hyperventilation. And they came back and were doing high fives to everybody. We got the tube in. But these two events just doubled this person's mortality. But we don't pay attention to this detail. And we know that many patients are going to require multiple attempts. That severe hypoxia with SATs of under 80% happen with significant frequency, as do severe hypotension. I remember when this came out saying, were they talking about a MAP of 65? No, systolic blood pressure of under 65. And in patients that are under resuscitated, we know that 2 to 3% of them get cardiac arrest, of which only half of them get ROSC. So this is the way we define success. Success is, I think that the standards are up there. I believe we should have first pass success rates of over 90%. And we need to be able to monitor that in resuscitation scenarios in critically ill patients. In patients that have saturations over 90%, we want to maintain them over 90%. In patients that have systolic blood pressures over 90, I want to maintain them over 90. And in patients that what I want to do is oxygenate and reoxygenate them in under 90 seconds. So why did I choose 90? Well, because all the other numbers have 90, but that's what it would take for you to critically desat, Ricardo. If I right now gave you, propofol and rock and didn't put any oxygen on, you would critically desat to under 90 under 80 in 90 seconds. So what do I mean by that? You need to train to do your primary approach in laryngoscopy in less than 45 seconds, and a vast majority of cases are done in less than 30 seconds, or less than 25 seconds, or even less than that. But we need to train to do bimanual laryngoscopy, how to respond to difficulty in less than 45 seconds. And if that fails, we need to be able to rescue them, whether it's with mass ventilation or with a supraglottic in less than 45 seconds. And those are two achievable things if we dedicate that time and dedicate our simulation to do it. So that was context. What about confidence? Mike Tyson, who got in the ring recently, embarrassingly, he shouldn't have, but he has a famous quote as a boxer, says, we all got plans till you get punched in the mouth. And we've all been punched in the mouth. It's part of what we do here. And this is this famous Dunning and Kruger, a couple of papers. This is a representation, is that when do we feel most confident is soon after our training. And this is the peak of Mount Stupid, right? Because we have all the knowledge, but we have none of the experience. And we are overconfident. And that was me. When I got out there. I finished on a Wednesday. I was working on a Monday. It was like, bring it in, I'm good. And then what happens, the real world happens, the valley of despair. And some people will be so bad that they'll leave their practice because it's so terrible. Now, what's wrong with this graph is that there's a slope of enlightenment and plateau of sustainability, but that's not life. Life is about this, right? There's ups and downs and all along the way, and we learn from our experiences over time. The number needed to be confident, this was a study that ultimately wasn't published, but they were looking at teaching medics how many tubes that they have to do to become competent. And they didn't achieve that goal. But who felt the most confident? The group that did 20, the group that did 15, or the group that did 5? It was the group that did 5. Why? Because they hadn't had the experience of difficulty. They hadn't been humbled by the real world. Right? So confidence is, you can be overconfident earlier in your career. And what are the experiences need to be confident in things such as doing a cricothyrotomy, a front of neck airway. We can't let experience be our teacher for things that don't happen very often. This was a study on looking at the temporary surgeon from an anesthetist point of view. And I thought it was a really well done piece. And it goes like this. You have an identity of as an anesthetist. You're trained. It's your specialty. You've got control of the snare. This is Adam Law, my colleague, and you have your identity as an anesthetist. On the other side, you've got the scenario where you might have to do a cricothyrotomy. You have to take on this role of being a temporary surgeon. in this area. So we have to resolve these two issues, and it's about training to reconcile this. And how do we do that? We need to understand context. One is that it's not considered failure to do a surgical airway. It's part of airway management, but it might happen never in your career, once or twice. And how do we reconcile this? Well, competence and confidence are closely linked. And the issue is that in times of stress, what we want to do, and I tell every person who works with me, you have to work to a set of comfortable discomfort, right? You need to be able, because then it's a challenge. Why are world records broken at the Olympics and the World Championship? Because there's that additional adrenaline that happens with it. But it's a fine line between that performance and that arousal going from a challenge and increasing performance to becoming a threat and impacting performance negatively. I refer to this as your psychological shock index. Is when your heart rate is greater than your patient's heart rate, then that potentially can affect outcome. And we know this based on some literature, is that you need, at a heart rate of 115, you start to lose fine motor control. And what do you need fine motor control for? You need it for laryngoscopy. You need it to be able to identify that median glossoepiglottic ligament, know that you need to be able to move another 3 millimeters down further to engage the hyoepiglottic ligament and touch that median glossoepiglottic ligament and lift it up. But you lose that with a heart rate of over 115. And we just did a study that'll be published soon about clicks that I've always said, I think it's a bit of rubbish that you're going to feel it when your heart rate's up. And we've got a study that we created stress and got people's heart rates up, and your ability to detect clicks are gone, essentially. But that's also fine motor movement. But what about gross complex motor movements? Well, performing a crike, you start to lose your ability to do that with heart rates over 140. And then the term lose your shit, where you can lose bowel and bladder, will actually happen from stress at heart rates of over 180. So we need to be able to control that. Confidence in this scenario, confidence can be a bad thing, right? I'm not sure I'm in. You're looking at that on the right, and you need to articulate that, right? There's no sustained waveform. And we all know about the papers that are out, and this is the prevention document that I had the privilege of being a part of. And confidence sometimes can be a challenge. I'm not going to go into this detail. It's a worthwhile paper that you should refer to. And the principle is you have to believe waveform. And if waveform, you have to have waveform. If waveform's not there, then you need to remove the tube and attempt ventilation. And this can happen to everybody, anywhere, anytime, regardless of your experience. Is not just something that happens to the inexperienced. In fact, some people will say the experienced are more likely because they can't believe that this is happening to them in that scenario. Because you've all seen, this was a paper that we published with Brindley and Laura Duggan. This seems simple. There's the airway, and it's obviously not the airway. And I think this is the one I shared with you, Ricardo. This is this looks like it's going in the right place, but it's not the right place. There's various recommendations that are out there. The first one is that everybody should have waveform capnography accessible to them, and that we can't let clinical grounds rule out, as a rule out, esophageal intubation. And that the default move is to remove the tube. Before you remove the tube, yes, make sure you're connected, so check on stuff before you pull out the tube, but that's the default move. Routine use of video laryngoscope is recommended. And all these pictures are esophageal intubations. Okay, so you will be humbled. I'm going to finish up with work ethic and work ethically. What work ethic means, don't be upset by the results you didn't get from the work you didn't do. Right, and what do we do is concert violinists, high performance athletes, they spend 95% of the time practicing and 5% of the time performing. What do we do in medicine? We spend all our time performing and very little time practicing, and that's a paradigm that needs to change. We need to be able to practice things that we don't necessarily do very often. And I'll ask people out there, since passing the quiz, since graduating, since writing your exams, how often do you regularly practice? And I think we'll reflect on that it's not as often as we should. So airway success, patient outcomes, it's about optimizing the patient in that environment. It's about optimizing the scenario around you. And it's about making decisions and knowing when to make the decisions. And I'm just going to take you through our algorithm and finish this. If you fail your first attempt, and if any point, right, that face mask ventilation or supraglottic ventilation is not working, you can't ventilate, can't oxygenate, you can call it whatever you want. There's too much debate over what to call it. This is when your psychological shock index is elevated. And you need to do certain things. You need to problem solve. This is one of the problem solving techniques that we're going to publish and show. I'm not going to show this right now. And then you need to problem solve with a supraglottic airway. And this actually shows, this is worth looking. So this is a supraglottic airway. You have poor waveform. And when you go down and look with a scope, you see the epiglottis actually bent down. And then by pulling it back, right, and doing a version of a Chandy maneuver, and then reseating it, right, then you push down, and all of a sudden you've got this as a view. So you need to problem solve that, but essentially you're being committed to doing a surgical airway. And the question is when? Well, my answer is this, is when waveform's abnormal and your sats start to fall. Right? Is there a number? It's under 90. We can argue about what that number is, but you're committed to doing a surgical airway. Errors of omission happen with twice the frequency as errors of commission. We're more comfortable doing nothing and failing than having done something that will be perceived as the cause of failure. So the person just died from their airway when really they needed to have a crike done. They needed to have a front of neck airway. Right? So we need to recognize that it's appropriate to do. We need to do simulation. We need to overlearn and do what we call system one learning. Overlearning is that for things that don't happen very often, we need to be better than good. We can't be just competent with this. And what overlearning does is allows you, when you to relearn it, is that curve upwards, you relearn it very quickly. And the slope, when you lose it, becomes longer and takes longer time before you lose it again. And then what we call system one training. And this is me doing 11 steps to do a front of neck airway. That's a practice opportunity. That's the psychomotor stuff required. This is us using our complex model in doing this, and just using tape that are there. We make all this stuff, and it costs less than $50 to make this stuff. And you'll be able to do at least 50 crikes on it. It allows you the highest fidelity crike model because it gives that lateral mobility that causes instability. And this is doing a scalpel finger bougie approach. We have the luxury of having cadavers, and you're going to see both the inside as well as outside here. This is again a scalpel finger approach. That's a finger in there. When your finger's in there, you will never forget the sensation of having cartilage completely surrounding your finger, right? And if it's a bloody airway, it doesn't matter. It's a tactile procedure. And we obviously have dropped the scope in so you can see this all happen as you do it. And then we also create scenarios of a bloody airway. And then it's worth maybe showing that. And again, this is maybe it's not going to show a bloody crike. And then also recognizing it's also good to increase your heart rate and do it under stressful scenarios. Are you good enough? We have to sort of believe that before I go to resuscitation, I say, listen, I'm going in, Ricardo's there with me. He's on my shoulder. Right. And if I do the stuff that Ricardo teaches or Rich Levitan teaches or others, then I can do this. It's positive self-talk. It changes your chemistry, and it changes your chemistry such that you can perform better instead of, oh my God, it's going to be a crike. I don't know what I'm going to do. Right. You have to turn that in. If I do what I'm taught to do, what I've trained to do, things are going to be okay. I do that. I go to the bathroom beforehand, and I do go to the bathroom because I'm in my 60s and I've got to, if I'm going to be in a resuscitation room for a while, I have to empty my bladder. But I do positive self-talk, and I do focused attention. I do control my breathing, work on my breathing beforehand before I go into a resuscitation. Work ethically. It's not about you. It's not owning the airway. It's about the patient, and that patient might be managed by you or a colleague to call a friend. I said 4 C's. There's a 5th C I'm going to say is curiosity. Expertise is not about doing what you do routinely, right? Expertise is about doing things that are out of routine, right? And so we can't just go in and do what we do every day and then being able to expect to translate it into going to resuscitate a sick patient. We need to spend the time in doing that. And then last C, and this is this in Atlanta when I gave a talk and I referred to the C's. This senior anesthetist woman came up and said, "You forgot a C, Dr. Kovacs," and that last C is compassion. And there's rigorous data show that healthcare providers spend more time looking into their computer screens or on their phones and looking to patients' eyes. And this is something I've been saying: is compassion can be naive, fragile, and easily lost. Its resurrection is linked to your health and your ability to see through the eyes of others. Don't play with fire. Own it and share it. I'm going to tell you what happened to this person, this 30-year-old. This wasn't here. This was in a small institution. We answered this. This was a place where there's a general practitioner and 2 nurses. This 31-year-old mother of 4 who came in with epiglottitis. 2 nurses, no backup, and a long transport. And she sent this email to us. By God's grace and your training, did an awake intubation using a glide scope. We transported the patient out with an ICU with a blessed 6-0 tube in for the entire stay, as he felt taking it out was too risky. We'd love you to share this case with your airway colleagues that reinforces why we do what we do and why you do what you do. Prepare and practice over and over again in case a young mom of 4 kids obstructs her airway due to epiglottitis in a hospital, has no OR, no anesthesia, no ENT. Can you imagine? These are the cases, and thank you. And sorry I went a bit over time because the questions up front may have taken a little bit of time. Thank you for the opportunity and the privilege to speak before you. Hopefully in the last little bit we can have some dialogue. Do you want me to shut my screen, stop share, or?
Sí.
Stop share.
Muchas gracias, querido George Kovacs. Realmente ha sido una experiencia mezcla de vida y mezcla de profesionalismo, lo que tú nos has mostrado hoy día. Creo que nos has dado muy buen material para reflexionar. Aquí esperamos a que los participantes nos envíen sus saludos, sus comentarios, sus preguntas. Hay expertos que nos están viendo también, que han asistido, como el doctor Raúl Silva desde Brasil, y algunos más. Y esperamos sus comentarios, los comentarios de los residentes que están en este momento presentes en el webinario. Pueden hacerlo pidiendo la palabra directamente o a través del chat. Mientras tanto, yo quisiera preguntarte, ¿cuál ha sido tu experiencia, George, en las intubaciones de urgencia usando bully? Tu experiencia, la tuya, usando bully o estilete con hojas hiperanguladas.
Yeah, so excellent question, and I think that the big mistake is you have to talk about it in context. So using a bougie out of the package with a hyperangulated blade should never happen. Right? It cannot work, right? Because you're using a C around the corner device, and otherwise you're taking a straight device with just a coude tip. So you do have to do what we refer to as doing a deliberate bend to use it. And so the answer, the simple answer is no, out of the package. And we haven't sort of seen the evidence, but we're increasing experience, and I'm sure it's happening at your institution and others, and increasingly people are using it. And you still have to problem solve it. In other words, with that deliberate bend, it will get still caught up sometimes on the cricoid cartilage, on tracheal rings. If you know how to move it off onto the smooth muscle by rotation, you're able to do it. Or even if it gets hung up, putting it in your tracheal tube over it, which will take it off of the tracheal rings. in that scenario when you get into difficulty. But I tell you why it does make sense is that if you're using you end up with a deliberately restricted view. The reason why the bougie is so successful with standard geometry blades isn't because of a lot of grade 3 views. It's because in those studies, it's actually with grade 2 views, the tube, as it approaches the glottic inlet, obstructs the view. And that's where the benefit of the bougie is just watching something smaller go in. So theoretically, it should have the same benefit doing it with a hyperangulated blade. You just have to, like anything, practice and know how to use it and problem solve with it. So I think that I'm not dogmatic as I was, that you have to use a stylet all the time with this. I think you can. I think we're seeing increasing success. The literature isn't out there yet to support it, but I think the experience is growing.
Exactamente, muchas gracias, George. Tú has tocado también un tema muy importante, que es algo que muchas veces nosotros en el quirófano no lo percibimos, porque la gran mayoría de nuestras intubaciones son hechas en un contexto de procedimientos electivos, no de urgencia. Y nuestros residentes les ocurre lo mismo. Su experiencia en situaciones de urgencia es ocasional, cuando se enfrentan a un paciente quirúrgico que requiere una cirugía de emergencia, o cuando somos llamados al servicio de urgencia o a la unidad de cuidados intensivos a intubar a un paciente que está en una situación crítica. Entonces ahí solamente nos vemos expuestos de manera ocasional al estrés mayor que significa intubar a un paciente en esas condiciones. Y en ese sentido es muy importante el manejo de la parte psicológica de uno, que va de mano a mano probablemente con la competencia que uno adquiera. ¿Crees tú que podrías darnos algunos consejos, algunos tips, de manera de que nosotros podamos ser capaces de manejar esta dificultad psicológica de la que tú hablabas?
Yeah, excellent point. I think, first of all, what's really important and what's great about where we are is that we have we don't have silos. There are still silos, in terms of between departments of who owns what, and it's this shared, right? And I think we're an example because of our history of people that had dual training and had a particular area of expertise in airway management. So we work together and we train together, and that's a helpful thing. I mean, simulation is critically important. I did my last podcast that I posted up there was all about this, and it's about high fidelity simulation for procedural learning and the problems with plastic. And what simulation is good for, and you don't need high fidelity stuff, is decision making, right? In terms of when to do what under scenarios, because a procedure is only as good as a decision is to do it, right? So that's simulation sort of creates that environment. But also, on the other hand, which really bothers me is that when we go to do the task-based stuff as part of simulation, yes, we can theoretically do it on these mannequins, but a lot of these actually reinforce bad behavior. And because even though the simulators can talk and do all these kind of things, the amount of force required, to do laryngoscopy, what it does is it promotes these things in the real world. When your adrenaline is high, the most common response to difficulty is doing the same thing over and using force over finesse, right? So you have to break down these tasks, and you have to break down the decision making, and you have to break down the procedural, and we have to spend more time and on having access to better simulators. And I have the great fortune of having access to clinical cadavers, which has really changed our world, right? It really has changed our world, is having access to this. But it's about creating this, and the problem is that they're in simulation. Psychosocial stress of other people watching you is very different than the stress of looking after a sick patient. Now, there still is that psychosocial stress of looking after a sick patient, because in our institution there are 10 people watching you in a resuscitation, because everybody's there, plus the performance that you're gonna have to do. And this is why I think video laryngoscopy is so critical, is it allows us to share that experience. It allows you to, in a timely manner, to be there and sort of, create a deliberate practice experience where you're able to see that you're down too far. You got to come back. You got to alter your handhold, et cetera. So you need to sort of share that, turn that fire as a bad experience into a shared meal where we're going to all benefit from it. So you can do that in the real world, in the resuscitation bay, by having video laryngoscopy and having it on a big screen, and sharing that kind of experience. And you have to break up your simulation decision making, and then the haptics of the procedure itself.
Muchas gracias, George. Quiero darle la palabra al doctor Raúl Silva desde Brasil. Hola, Raúl.
Olá, olá, Dr. Tubia, Dr. Lantrop, Dr. Kovacs. Parabéns pela apresentação. Estou falando em português também, que eu estou vendo que tem mais gente do Brasil aqui no nosso webinário, né? Dr. Kovacs, queria fazer um comentário e aproveitar também fazer um questionamento para o senhor. O senhor mencionou o livro Outliers, do Michael Gladwell, né? Que é um livro muito, muito interessante, que fala sobre fatores culturais, né? Como a relutância no questionamento da autoridade, principalmente na aviação, né? Na aviação principalmente dos países asiáticos, né? Já no manejo da via aérea, né? A gente também tem uma grande é, é, problema em relação às habilidades não técnicas, que muitas vezes levam a problemas de comunicação e liderança de não inclusão, né, das opiniões de pessoas que não são líderes, né? Foi o que aconteceu no clássico exemplo da Elaine Bromley, né? E que teve um problema no progresso do próximo passo na decisão, na tomada de decisão. Então, eu queria saber do senhor, Dr. Kovacs, quais estratégias, na sua experiência, o senhor considera mais efetiva para prevenir esses erros de liderança, né, que possam levar a desfechos catastróficos, né? O que o senhor utiliza na sua prática? Obrigado.
Yeah. Thank you for raising that question. It's critically important, and it's not unique to this is ubiquitous everywhere, there's been a lot of time appropriately spent on this. And the way that I do this, and probably the most common scenario for me is being as a trauma team leader, where you're bringing together various services that are present, right? So we've got orthopedics, we've got anesthesia, we've got general surgery, we've got respiratory therapists, we've got a whole group. So the first thing is to brief the room if you have an opportunity. And briefing the room, sometimes you have notice, sometimes you don't have notice. But even if it's a 30 seconds, this person's coming in, and most of the time you do have time. Summarize the scenario. And articulate your plan, and then invite comments as to about this plan. And this is all about success. Here is about having a shared mental model. And unfortunately, the only person we're sharing our mental model with is one part of our brain to another part of our brain. and not necessarily with the people that are in the room. And so that's one, as a leader, is to be able to do that. Secondly, is to then again delegate appropriately. So if I'm at the head of the foot of the bed, from a leader point of view, then there's the airway team that's up at the top of the bed, and which in our situation, you know, the emergency physician or emergency medicine resident or anesthesia resident or an anesthesia staff, depending on the scenario. So they articulate their component to that, right? And then invite feedback. The other part, and we all know that what this has failed in terms of catastrophic outcomes from unrecognized esophageal intubation, and is that by doing that brief, you invite people to sort of speak up, right? And what we sort of said as part of that other document is to articulate, you know, a full view of the glottis, don't describe it as a grade 1, 2, 3 or whatever, full view of glottis, tracheal tube visualized pass through the cords. It gives an opportunity for the person that's up there sharing a screen, and this is the benefit of having video laryngoscopy, to say, I'm not really sure there, right? Or for somebody to say, and part of my pre-brief is saying is that the most important thing on the monitor is not the SATs, it's waveform. Right? Because SATs are going to fall. They're going to take a while to fall. They're going to take a while to get up. Everybody has permission to say at any point, if they don't see adequate waveform, to articulate that. There's always somebody in the room who's calling out the SATs as they're falling, but that's too late, right? So pre-briefing the room, inviting input, and making sure that we all look at the appropriate monitors, both waveform and saturation monitor, inviting input and sharing views in terms of video laryngoscopy, and articulating out loud what's happening, which allows an opportunity for people to get in. And then the final thing is to do a post-brief afterwards, right? Is to spend that time afterwards as a group to sort of say what went well, what didn't, because that creates the culture. And then the last thing I always do is thank everybody. Thank everybody for your input. A medic comes in, delivers a patient before they leave the room. Thanks, you know, excellent job, right? So that you have to by example create a positive culture, and that's the best way is you by example. Long answer. I could go on and on about that, but thanks for the question.
Muchas gracias, George. Muchas gracias, Raúl, por tu pregunta. Desde La Paz, Bolivia, te envía muchos saludos el doctor Mario. No puso su apellido, pero el doctor Mario de La Paz, Bolivia. Te envía muchos saludos. Yo creo que ha sido una jornada tremendamente provechosa, muy, muy rica en diversos aspectos de vida, de experiencia, de profesionalismo. Y creo que los que hemos tenido el privilegio de escuchar el mensaje que nos has entregado hoy día, creo que nos vamos con una enseñanza no solamente profesional, sino que también, y por sobre todo, experiencia de vida. Te mandan saludos la doctora Vilma Medina desde Tijuana, México, George. Sí.
Thank you all. Thanks for the privilege of being here, and I hope to make this in person at some point. But and thank you for all doing what you do every day, and leading by example. So be well. And as Ricardo says at the end of every email, hugs. Right? That's what he says. Hugs.
George, te quiero presentar, por favor, al doctor Ricardo Latrop, que como lo mostré al principio de la sesión, es el director del programa de anestesiología y reanimación de la Universidad Diego Portales. Y él siempre nos acompaña, así que lo dejo a él para que te salude.
Bueno, doctor Kovacs, ha sido un placer escuchar su conferencia. La verdad, creo que el tema del factor humano, el tema del liderazgo frente a situaciones de mucho estrés o en las cuales hay cometido las situaciones vitales de pacientes, es un tema que como grupo médico tenemos que abordar, entrenar. Siempre el anestesista teóricamente va a ser el líder. Y por lo tanto, creo que es un tema extremadamente valioso de abordar. Le quiero dar las gracias en nombre de nuestra universidad, de nuestra facultad de medicina, de nuestro decano, de la directora de la dirección de posgrado, obviamente de parte de la jefatura del programa, el haber participado, el habernos ayudado a poder tener una conversación como esta, escuchar su experiencia. Muchos de nosotros que ya tenemos hartos años en esta especialidad, sin duda hemos vivido situaciones críticas, situaciones en las cuales hemos sentido que quizás nos faltó más entrenamiento, más racionamiento, eh, y muchas veces uno aprende de lo que ha ido pasando en la vida y es fundamental no solamente entregar la capacidad de enseñar técnicas, enseñar dispositivos, sino que básicamente también es muy relevante enseñar actitudes, pensar en lo que estamos haciendo, la responsabilidad que adquirimos. Cuando un enfermo respira por su cuenta, es responsabilidad de él. Cuando nosotros lo dormimos y deja de ventilar, es responsabilidad nuestra. Y ese entrenamiento constante nos debe llevar a cuando enfrentemos situaciones de extremo estrés, nos debe evidentemente tamponar la adrenalina que inevitablemente vamos a tener. Y el liderazgo solo se hace ejerciéndolo con tranquilidad. Yo siempre les digo a los residentes, cuando tú pierdes la calma, pierdes el enfermo. Y la calma se basa en lo que hemos aprendido de nuestros profesores, de nuestra experiencia, de webinarios como este, de escucharlo a usted. Por lo tanto, siempre no solamente es un aporte la experiencia de gente que ha estudiado el tema del factor humano, sino que además agradecerle la oportunidad de escucharlo y en nombre, como le digo, de todo nuestro equipo de la universidad, darle muchas gracias a doctor Kovacs por estar con nosotros y ayudarnos en la formación y en la adquisición de experiencia de nuestros residentes. Muchas gracias, doctor Kovacs.
Thank you again. It means a lot. It means a lot to me. It's not about the most important accolades that I get are when I hear from individuals who feel comfortable in sharing their experience, and that I can be there to support them, and them support me. So yeah, thank you. One thing when we do is when people call for help in general, I say is that they're not calling for knowledge most of the time. They're calling for experience, right? And they may or may not have that experience, and it could be that experience is talking to you. It could be that experience in a remote area that there's a paramedic or a pre-hospital person or somebody who's at home or whatever it is. But it's important that we appreciate that because these things sometimes happen so infrequently that we have to rely on the collective experience. And that's what matters. And we need to support each other when we think we're at the top of the heap to sort of bring people down to reality. And on those days when it's been a very, very tough day, whether it's because what happened at home or what happened at work, we will continue to have that. And it's important to support each other. Thank you again for doing what you do and giving me the opportunity to share my experiences.
Muchas gracias, George. Ya nos veremos en alguna oportunidad. No sé si vas a ir al UAM en Florencia el próximo año. Si vas, ahí te daré un abrazo grande y te agradeceré personalmente este esfuerzo tan generoso que has tenido hoy día con nosotros. Muchas gracias. Bueno, gracias a todos. Permítanme compartir nuevamente la pantalla. Quiero mostrarles algunas cosas para despedir la sesión, tenemos nuestro webinario en las redes sociales, también está el programa de anestesiología, tenemos el canal de YouTube, ustedes pueden ver todos los webinarios que hemos realizado desde ya hace casi 4 años, accediendo al canal de Anestesia UDP o también activando el código QR que tienen en su pantalla. Próximamente va a estar incluida este webinario completo. Estamos también en Instagram, en X, y quiero anunciarles el próximo webinario que tendremos el día sábado 21 de diciembre, poco antes de Navidad, en el cual la doctora Ellen O'Sullivan, la profesora Ellen O'Sullivan de Irlanda, nos va a hablar sobre eventos adversos en el manejo de la vía aérea y cómo minimizarlos. Ella es una anestesióloga de muy dilatada trayectoria y experiencia, y gran experiencia en estos casos, y ha tenido una trayectoria docente también realmente muy relevante. Así que no se pierdan este próximo webinario donde la doctora O'Sullivan nos va a ilustrar sobre este tema. Muchas gracias a todos, muchas gracias George nuevamente, en nombre de la universidad, como te decía el doctor Latrobe, estamos muy agradecidos por tu generosa contribución a esta actividad académica universitaria. Muchas gracias a todos y que pasen un buen fin de semana.
Thank you.